Good evening, everyone. Welcome to Unacademy, where you can crack all NEET PG exams with us, with our top educators, quality content, and have a great learning experience. So, guys, let's crack NEET PG together. A little about me. I'm Dr. Sasha Menon Remedius. I've done my MBBS from Father Muller Medical College, Mangalore. MD in Anesthesiology from Father Muller Medical College, Mangalore. I have 2 publications and 1 paper presentation in the field of anesthesia, and I've been working and teaching in Bangalore for the past 2.5 years. So today's topic is a quiz. I have combined 2 topics. I have covered these topics on this platform, and I have taken the quiz on these topics 2 individually, and now I have combined these 2 topics, and it's left for you all to see what they are. So guys, a little about Unacademy. It's one of India's largest online learning platform, which has plus subscriptions and access to unlimited live and recorded courses from India's best educators. Now, what will you get out of Unacademy? So we have our daily live classes. So basically, when you all go to a coaching institute, you all waste time and energy just to get till there, first of all, traveling, getting ready, etc. And you'll need to get there in time and etc. And then, of course, after that, you'll have to see that you'll get in a good place where you all can see the educator and you all can see the screen, and not always will you all be able to get that. And then, of course, the educator cannot clear everyone's doubts because it's in that 1 hour time frame and there are so many students. It's a little difficult to hear each one's doubts out and all, because while he's teaching he loses the flow of thought and etc. So it's a little difficult for the educator to clear everyone's doubts, whereas here at Unacademy you can chat with your educator and engage in discussions and clear your doubts about the class while the class is going on. Then, of course, we also have then like I said, so it's a little difficult for even you all to clear your doubts because big classes, etc. Then these are structured courses. All the courses are in line with your exam syllabus and help you best prepare for it, so that you all are best prepared for it. All these subjects are researched, and whatever is needed best for you all to help you all score, we prepare based on that. And then we have our live tests and quizzes, so this will help you all evaluate your performance on a regular basis with our live tests and quizzes, and you all can get a detailed analysis on your performance. So like today I've prepared a quiz for you all. So on a regular basis, like I said, because practice makes you all perfect. You all need to keep practicing, keep revising, and the only way is if we go on going over the topics again and again. So repeated quizzes, mixed quizzes, it's all very helpful because we discuss it with you all and it's like a revision for you all. And of course, you all have unlimited access, so one-time subscription, which you all have access to all our live and recorded courses, and you can watch them from the comfort of any of your device and wherever you are, from your home or wherever it is. Now, these are some of our top educators. Dr. Nikita Nanvani, she is a PG mentor in radiology as well as mnemonics and concept focusing on must-know topics which encompass all subjects. Dr. Mohammad Azam, Dr. Divish Mishra, Dr. Preeti Sharma. Mnemonics are really helpful, and I suggest that you all make your own because it will be much easier for you all to remember too. Of course, when somebody is helping you all, it is very helpful. Go through the mnemonics, make your own, take ideas from the mnemonics which are already made. It really does help. These are some of our courses offered. As you can see, there are about 19 subjects, and under each of the subject there are various courses. Now the smaller subjects, like they were smaller during your MBBS. These are not small subjects. Anesthesia, radiology, psychiatry, they were not really very, you didn't have to really cover them that much in detail, right? They were short postings of 1 month or so. Internship was like 15 days or whatever. So we don't really know much about these topics. These are vast topics, and about 11 points are awarded to each of these in NEET PG, and these 11 points are scoring points, because like how you all didn't have to go into depth even during the exam, they will not go into depth question answer wise. Whereas your anatomy, physiology, of pharmacology, of course, those are like those were the main topics. They are still the main topics. NEET PG wise rewarded around 44 marks each. so that they can ask you all anything from anywhere. Whereas with these smaller, I mean the subjects which are allotted lesser marks, they will just generally just ask you all the cream of the cake. So you all need to focus on that. Don't lose your points. It's really important. These are some of the ongoing courses in our platform. Neurophysiology, GI surgery, cardiovascular thoracic surgery, capsule on larynx, respiratory system, pathology. Now coming to the subscription part of it, as you all can see, there are 5 types of subscription on your screen, and 136. I would not recommend you all to go for those subscriptions. I would highly recommend that you all go for the 12 and the subscription. Now, why I'm telling you all that is, first of all, it's not easy to clear in 6 months. Like I said, 19 subjects, and you'll have to go into depth in each of in these depth into these subjects. They can ask you all anything from anywhere. These are not easy subjects. You all have gone through it each year in MBBS. You know how the university exams were, how stressful it was. I'm not saying it's impossible to do it in 6 months, but yes, it is a little tough to complete it in 6 months, right? So I would really suggest that you'll take 12-24 months. At the end of the day, it's knowledge. You all are not losing anything. Also, like I said, the subjects where you all didn't have to focus much during MBBS, you all really don't know much about the subject, right? So when you are studying in that 12 and the 24 months, you actually get to know about all these subjects. And you might want one subject, but when you're studying, you might realize, okay, this is not for me. I actually like the subject which you never really had the chance to experience. Okay, I'm not saying that you all are going practically into it while studying, but still theoretically also it gives you an idea, and you all will of course get inquisitive, look on Google and this, that and all, and come up with stuff about the subject. So that's how I took up anesthesia, and I'm really happy. So you all will be doing this for the rest of your life, so you all need to know what you all pick up is like the one, right? So it really does help taking that time and studying the subjects and knowing what you want. So I would recommend that you all go for. Also, it is economical. It's a one-time subscription. So after 6 months, once your subscription is over, you'll have to subscribe again if you want to go through the classes. If you want to chat with your educator, clear your doubts, you will have to subscribe again and pay again. Whereas with your 12 and the 24 months, it's one-time subscription. So do subscribe, use my code at the bottom in red, and you all can avail a 10% discount. So use the code at the bottom, red, like you can see in red, this SASHA. This is the code, and avail a 10% discount. Okay. Now again over here, like I said, use the code at the bottom. 24 months. It's not everyone's cup of tea to do it in even 12 months. Take your time, no stress. Nobody will ask you at the end of the day how long you took to clear NEET and become a doctor. Nobody's really bothered about that. Once you practice, nobody really cares about it. So it's at the end of the day, it is how much, what you have gained, the knowledge you have gained, the practice that you have done. So 24 months, nothing wrong. Take your time. If you feel you need it, then do it. You will get again a 10% discount if you use my code and subscribe. Of course, we have 3 platforms. This is the YouTube platform, we have the special class platform, and the subscription platform. We do different classes on these platforms. So if you all want to access the entire syllabus, you all can please, for the special classes, log on to the app, and for the subscription classes, kindly subscribe. So now we'll move on to our topic for today, the combined quiz. I'll be giving you 1 minute per question, and I will be setting a timer for 1 minute. So let me get to the timer, and then we will come to our first question. Okay guys, just a sec. Okay, just a sec to the timer. Set our timer for today for 1 minute. Okay, we're all set. So our first question for the day: all are true about single twitch stimulation except. The single supramaximal stimuli applied to a nerve at frequencies from 1 to 0.1 Hz. That is once every second and once every 10 seconds. Height of response depends on the number of unblocked junctions. Pre-relaxing controlled responses noted and compared with subsequent responses, depolarizing and non-depolarizing blocks. there is a difference in decrease in twitch height. Your time is up, and your check your answer is number 4. So with a single twitch stimulation, depolarizing and non-depolarizing, there is no difference in decrease in twitch height. So whenever there is a depolarizing and a non-depolarizing block, when a single twitch stimulation is applied, there is no decrease in twitch height. So with your train of 4, you will actually see a decrease in twitch height occurring, right? Like this, a decrease in twitch height. With there will be a difference between your depolarizing and non-depolarizing, but with your single twitch there is no difference. This is actually a disadvantage of single twitch stimulation. Okay, so this is actually a disadvantage of the single twitch stimulation, because you cannot differentiate between the depolarizing and the non-depolarizing block. Of course, a single supramaximal stimulus is applied to a nerve at frequencies from 1 hertz once every second and zero point 0.1 hertz once every 10 seconds. The height of response depends upon the number of unblocked junctions. So if there are more number of unblocked junctions, the height of the response will be more. If there are less number of unblocked junctions, the height will be less. Basically, if everything is blocked, you will see no response to twitch. Pre-relaxant response, control response has to be noted and compared with subsequent responses. So this is another disadvantage. Okay, with the other modes of stimulation, you don't really need a control, right? But in this you need a control. So before relaxant is given, a control response will have to be elicited, and the response with after giving relaxation will have to be compared to this control response. So this is a disadvantage. So basically the other two are, the last two are disadvantages. One is there is no difference between depolarizing and non-depolarizing, and a pre-relaxant control response is needed. Your next question: all are true regarding TOEF except four supramaximal stimulus are given every 0.5 seconds, that is 2 hertz. Fade in the response provides the basis for evaluation. The ratio of the height of the fourth response to the first response is the TOF ratio. In partial non-depolarizing block, T4 by T1 ratio is proportional to the degree of blockade. So all are true in TOF. So this is kind of like a trick question. So 4 supramaximal stimuli are given. 1 minute, just a second. Yeah, sorry. Just a sec, it seems to be stuck. So yes, 4 supramaximal stimulus are actually given. Just a sec, I am having some problem. Just give me a second. So the first one is true. 4 supramaximal stimuli are given. Okay, and they are given with the fade in response. So basically, train of 4 is the response, the ratio of the fourth response to the first response. So it is basically a mode of neuromuscular monitoring. So it is a mode of neuromuscular monitoring. So TOF is train of 4 ratio. So it is basically the ratio of the fourth response to the first response. And in non-depolarizing block, so in depolarizing block, there will be no response. Basically, there will be no fade seen. So the fade is basically, just a sec. So, like I said, the first one is true. 4, I think, yeah, now it's okay. The conduction or whatever, I don't know, I was having some problems, sorry. So, 4 supramaximal, again, there is some problem. So, 4 supramaximal stimuli are there, way back. 4 supramaximal stimuli given 0.5 seconds apart. Fade in the response provides the basis for evaluation. So, the ratio of height of the fourth response to the first response is the TOF ratio. So basically this is your TOF. So 1, 2, 3, 4. So the ratio of the fourth to the first. So this is T4 and this is T1. So the ratio of the fourth to the first provides is basically your TOF ratio. Higher the TOF ratio. So if the TOF ratio is 0.9, it means adequate reversal, that is, in the sense, adequate return of neuromuscular function, and reversal agent can definitely be given. Now this is your wrong statement. So in partial non-depolarizing block, so the non-depolarizing block, T4 by T1 ratio is inversely proportional to the degree of blockade. So it is not proportional, it is inversely proportional. Okay, so in the sense, T4 by T1, if the degree of blockade is high, so it is inversely proportional to the degree of the blockade. In the sense, if the degree of blockade is high, T4 by T1 will be less, inversely proportional to degree of block. Okay, that is, if the degree of block, that is, if the block is very intense, okay, degree of block suppose is intense, then your T4 by T1, so basically here the degree intense in the sense the degree of block is high, very high, your T4 by T1 will be very less, so it will be around 0.1. When your degree of block is very less, so when more neuromuscular receptors are free, then your T4 by T1 will be high, that will be around 0.9. Okay, so it's inversely proportional to the degree of blockade. All are true about TOF except in partial depolarizing block, T4 by T1 ratio is inversely proportional to degree of blockade. In depolarizing block, no fade occurs in TOF ratio, so equal depression in twitch height. Fade in depolarizing block signifies the development of phase 2 block. Fade in the response provides the basis for evaluation. Oh, I'm sorry. And starts now. All are true except. Okay, so in this actually all are true. Okay, each and every statement in this is true. So we'll discuss the statements. So we discussed this in partial non-depolarizing block. T4 by T1 ratio is inversely proportional to the degree of blockade. We already discussed that. In depolarizing block, no fade occurs in TOF ratio. So equal depression in twitch height. So when there is a depolarizing block, there will be no fade. That is with your succinylcholine. There is no fade. So it will be all will be similar, right? So this is your depolarizing. There will be no fade. In your depolarizing, non-depolarizing, of course there will be a fade. This is your non-depolarizing. Now this fade is produced because of action of the drug on uh, pre-junctional receptors. Okay, so these pre-junctional receptors are basically receptors that are located on the nerve. Okay, so succinylcholine does not act on receptors located on the acetylcholine receptors, which are located on the nerve terminal, that is your pre-junctional receptors. However, non-depolarizing agents bind to the pre-junctional receptors which are located on the nerve. However, fade in depolarizing block. So when in with succinylcholine, if there is a fade, it signifies a phase development of a phase 2 block. But technically in a phase 1 block, that is normal succinylcholine function, unless phase 2 is mentioned, there will be no decrease in no depression in there will be equal depression in twitch height. So there will be no fade. So fade is a response that provides a basis for evaluation for TOF. Yes, that we know. Your next question. All are true about tetanic stimulation except it is painful. Results can be obtained with TOF, visual or tactically unpredictable. During normal neuromuscular transmission and non-depolarizing block, the response is sustained. So, all are true about technique stimulation except the number 4. So, during normal neuromuscular transmission and non-depolarizing block, the response is not sustained. You will see a fade with tetanic stimulation. So, with depolarizing block, response is sustained. So basically what happens during tetanus is a 50 hertz stimulation is given for 5 seconds. Okay, now 50 hertz is a huge amount, so it is very painful. Okay, the same results that are obtained with technique stimulation, that is the fade with the non-depolarizing and no fade with depolarizing, can be obtained with TOF, and it is not 50 hertz less painful. And of course this is visually or tactically unpredictable. You cannot really, it's not this method is not suitable to for tactile prediction by putting the hand on the muscle and feeling the contractions. It is not predictable. So these three are covered in that. So now what happens during tetanus is there is depletion of acetylcholine output. This is during tetanus, during a tetanic stimulation, that the depletion of acetylcholine is balanced by mobilization from stores. Okay? This is balanced by mobilization from stores. But when you give a non-depolarizing muscle relaxant, this non-depolarizing muscle relaxant will decrease uh, functional receptors and decrease mobilization of the stores. This contributes to the fade that we see. So this contributes to the fade. So basically during tetanus, the depletion of acetylcholine output is balanced by mobilization from the stores. However, when a non-depolarizing muscle relaxant is given, it decreases the number of functional receptors because it binds to these receptors, and hence it decreases the number of functional receptors. And when it decreases the number of functional receptors and decreases mobilization, it produces fade basically. So tetanic stimulation is also followed by post-tetanic facilitation. So this tetanic stimulation is followed by post-tetanic facilitation. That is, there's increase in mobilization and synthesis of acetylcholine. So this mobilization and synthesis, it continues even after the tetanic stimulus is stopped. So that leads to a post-tetanic facilitation, right? So the post-tetanic response will be seen. Now your next question. All are true about post-tetanic stimulation except. So mobilization and enhanced synthesis of acetylcholine continue during and after cessation of tetanic stimulation. Return of the fourth response to TOF is related to PTC, used to assess the degree of neuromuscular blockage when there is no reaction to single twitch or TOF. Number of post-tetanic twitches correlates inversely with time for spontaneous recovery. Okay, time is up. So the answer is number number 2 is your answer. All are true about PTC except this, the return of the first response. The first response to TOF is related to PTC. So post-tetanic stimulation basically, which leads to the post-tetanic count. So basically, mobilization and enhanced synthesis of acetylcholine we discussed in the previous question continue uh, after cessation of the tetanic stimulation to producing this PTC. It is used to assess the degree of neuromuscular blockage when there is no single reaction to single twitch, TOF, double burst. There is no reaction at all. This PTC is helpful to assess the degree of neuromuscular blockade. So, when the number of post-tetanic twitches correlates inversely with time for spontaneous recovery. This is like TOF only. The more the number, the less time for spontaneous recovery is required. The more the number of post-tetanic twitches. So basically, uh, uh, it is a single twitch after tetanic stimulation. So after a tetanic stimulation, a single twitch stimulation, one hertz at 3 seconds is given to assess this PTC. Okay, so a PTC of basically when there are uh, a post-tetanic count of basically when there is one response uh, of TOF, it indicates that there is some recovery. So not the fourth response, fourth response generally. So return of the first response of TOF is related to PTC. That is the plane of anesthesia has become less deep. Fourth response of TOF is basically you know that the plane is not very deep. So the return of the first response of TOF is related to your PTC. All are true about double burst stimulation except so double burst consists of two train of 3 impulses at 50 hertz tetanic stimulation separated by 750 milliseconds. Duration of each impulse is 2 milliseconds. Double burst stimulation allows a manual detection of residual blockade under clinical conditions, and tactile evaluation in DBS 3/3 is superior to TOF as human senses. DBS fade better. So basically, DBS consists of two chain of 3 impulses at 50 hertz. So two chain of 3, that is like this, impulses at 50 hertz, tetanic stimulation separated by 750 millisecond. Okay. All are true except this. Duration of each impulse cannot be 2 milliseconds. So you all have to understand these are very high stimulation impulses. They are very painful. You cannot stimulate the muscle for 2 milliseconds. It will go into tetany. So it is actually 0.2 millisecond. You all need to know the timing for these this nerve stimulation. So double burst stimulation allows manual detection of residual block under clinical conditions. So this double burst stimulation is the one which is adequate to detect which is good for manual detection of residual blockage. So tactile detection is pretty good with double burst stimulation. So tactile evaluation of fade is superior to TOF as human senses sense double burst stimulation fade better. Okay, so because human senses sense this double burst stimulation fade better, it is superior for tactile evaluation. However, just because there is tactile presence is there, if even though there is tactile presence, it does not mean that recovery is full. Okay, all the clinical signs etc. have to be assessed before reversal agent is given, and it is come to a conclusion that recovery is full. So also in your post-tetanic stimulation, the previous slide I forgot to tell you, in your PTC, it is used even for during surgery when sudden movement is not needed. So in surgeries like ophthalmic surgeries and your neurosurgery, when they are operating on the brain, when they keeping the patient awake, when they're operating on an epileptic foci, they need the patient to respond. So your neurosurgery, ophthalmic surgery, where they cannot paralyze the patient, where they do not require the patient cannot move, and if the muscle relaxant is not being given, post-tetanic stimulation can be used to monitor the depth of anesthesia. So it has to be in a plane where there is no response to anything, including post-tetanic stimulation. So it is used to monitor no responses, that the plane is intense, very deep, reversal cannot be given. The next question, all are true except, all are true statements except surgical blockade begins when the first response to TOF stimulation appears. Presence of one or two responses to TOF indicates sufficient uh, relaxation. Recovery, return of fourth response of TOF heralds recovery phase. Presence of spontaneous respiration is also a sign of recovery. Adequate neuromuscular recovery, T4 by T1 ratio more than 0.9 excludes clinically important residual neuromuscular blockade. Antagonism of neuromuscular blockade should not be initiated before at least two TOF responses are observed. Okay, your time is up. The answer is number 2. Okay, so yes, return of train of 4, fourth response of train of 4 heralds recovery phase. This part of the statement is correct. So fourth response always indicates that the recovery phase has begun, but presence of spontaneous respiration is not a sign of recovery. Okay, it does not mean, it is not an individual sign of recovery. It is clinically, yes, it is a sign encompassed, but when you read all the statements, this is not wrong. It is a sign of recovery, but you cannot base it as a sole sign of recovery, right? So it is not a sole sign of recovery, but all the other statements are true. So it is not a sign of recovery. So surgical blockade begins when the first response to TOF stimulation appears. Presence of one or two responses indicates sufficient relaxation, right? So when the first response of TOF appears, that means that there is surgical blockade is initiated, and one or two responses to TOF. When there are only two responses, that means there is adequate relaxation. So a T4 by T1, so the return of the fourth response, when your fourth response is present, that's when you know that it is now in the recovery phase. So presence of one response is sure short indication of surgical blockade, and two responses means it is sufficient. The surgeon can start. Uh, the ratio of T4 by T1 more than 0.9 excludes clinically excludes important neuromuscular blockage. So when the ratio is 0.9, it is almost 95% of the time it is sure shot. There is no residual neuromuscular blockage. So antagonism of neuromuscular blockage should not be initiated before at least two responses are observed. So 2 to 3 TOF responses have to be present before reversal agent can be given. Otherwise, reversal should not be given. It will high chances of inadequate reversal occurring. All are true about acceleromyography except this technique uses miniature piezoelectric transducer to determine the rate of angular acceleration. Muscle must be able to move freely. The piezoelectric crystal is distorted by the movement of the crystal inlay transducer, which is applied to the finger, and an electric current is produced with output voltage proportional to the deformation of the crystal. This is an isometric measurement, and there are stringent requirements for immobilization of arm, fingers, and thumb. Also, preload is necessary. All are true except. Okay, the answer is number 4. So this is a non-isometric measurement. It's a non-isometric measurement, and this is not true. There are no requirements for immobilization of the arm, finger, and thumb. So the arm, finger, and thumb need not be mobilized. And no preload is necessary. So you do not require preload for this mechanism. You do not need to immobilize the arms, finger, and thumb, and it is a non-isometric measurement. So it uses a miniature piezoelectric transducer to determine the rate of acceleration. Yes, so a small transducer is used to determine the movement of the muscle. Muscle has to be able to move freely. So the piezoelectric crystal is distorted by the movement of the crystal which is inlaid in the transducer. So there is a crystal which is in the transducer which is applied to the finger. So when an electric current deforms the finger, produces a contraction in the finger, the piezoelectric crystal is distorted by this crystal which is in the transducer applied to the finger. So here you go. An electric current is produced with an output voltage proportional to the deformation of the crystal. So depending on what the deformation of the piezoelectric crystal is, an electric current is produced and a graph is produced, right? So a visualization of will be produced based on the mobilization of the crystal. All are true about mechanomyography except these devices are difficult to set up for stable and accurate measurements. Proper transducer orientation, isometric conditions, application of a stable preload is not required. Uh, Maintenance of muscle temperature within limits is important and quantifies the force of isometric contraction. So in mechanomyography, we actually need a preload. So over here, this is wrong because a preload is needed. Okay, a preload in mechanomyography is needed. The device is difficult to set up for stable and accurate measurements, and it is under isometric conditions. A preload of about 200 to 300 grams is needed, and the alignment of thumb with the transducer is very important. So you need alignment of thumb with transducer. So alignment of the finger, 200 to 300 grams preload, and the transducer has to be constantly zeroed. For stimulation, right? So it is a little difficult to, and does not give accurate measurements. Proper transducer orientation and zeroing is required, and there is of course the muscle temperature has to be maintained within uh, limits is important. All are true except the relative risk for transient neurological symptoms after spinal anesthesia with lignocaine is higher. The addition of vasoconstrictor to local anesthetic solutions may decrease the risk. This is with respect to local toxicity, local tissue toxicity. Patient undergoing surgery in lithotomy position appears to be at increased risk for neurological symptoms, and spinal anesthesia with local anesthetics can produce transient neurological symptoms. Oh, sorry guys. I'm sorry. Mistake. Sorry. Yes. The answer is number 2. So with respect to local toxicity, uh, the risk for transient neurological symptoms after spinal anesthesia with lignocaine is higher. So with lignocaine, the risk for neurological symptoms is higher. The addition of vasoconstrictors to local anesthetic solutions actually increases the risk of toxicity, right? Because there is increased ab- absorption into the blood, so it actually increases the risk of toxicity. Patients undergoing surgery in the lithotomy position appear to be at increased risk for neurological symptoms. This is in addition to the toxicity caused by the local anesthetic. It is also um, due to the position related, okay, because of compression, prolonged compression. And spinal anesthesia with local anesthetics can produce transient neurological symptoms. That is a well-known fact. All the following statements are true except all local anesthetics, but especially lignocaine, can cause rapid and profound cardiovascular depression. Plasma concentrations 5 to 10 microgram per ml of local anesthetic may produce profound hypotension due to relaxation of arteriolar vascular smooth muscle and direct myocardial depression. Um, Part of the cardiac toxicity that results from high plasma concentrations of local anesthetics occurs because these drugs also block the cardiac sodium channels, and slow conduction of cardiac impulses through the heart manifests as prolongation of the PR interval and QRS complex on the ECG. Okay, your answer is number 1. Oh, I'm sorry. It's actually number 1. All local anesthetics, especially bupivacaine, not lignocaine. Bupivacaine causes rapid and profound cardiovascular depression, right? Plasma concentrations 5 to 10 microgram per ml of of local anesthetics can produce profound hypotension due to relaxation of the smooth muscles and direct myocardial depression. This is true. Part of the cardiac toxicity is also because these drugs block the cardiac sodium channel. So the mechanism of action is blocking of sodium channels of local anesthetics, and they manifest as prolongation of PR interval and QRS complexes on the ECG. Which statement is true with regard to the CC-CNS ratio? CNS more resistant to toxic effects of local anesthetics. With moderate CNS toxicity, bradycardia and decreased cardiac output. Onset of convulsions is an ominous clinical sign of devastating cardiovascular event. CC-CNS ratio, the lower the ratio, more safe. Which statement is true? The answer is number 3. So onset of convulsions is a sign of actually a devastating cardiovascular event. So the CC-CNS ratio is nothing but it is a ratio of the blood levels required to produce cardiovascular collapse to the blood levels of the local anesthetic required to produce convulsions. The blood level of local anesthetic required to produce cardiovascular collapse to the blood level required to produce convulsions is a CC-CNS ratio. The CVS is more resistant to the toxic effects of local anesthetics. The CNS gets affected first. With moderate CNS toxicity, tachycardia and increased cardiac output. So there will be tachy plus increased cardiac output. Initially, there is an excitability phase with seizures, increased cardiac output, tachycardia with moderate CNS toxicity. Onset of convulsions indicates a devastating cardiovascular collapse is impending. That is correct. So the lower the ratio, more hazardous, not safe. So the lower the CC-CNS ratio, more hazardous because more chance of collapse. All are true about methemoglobin except methemoglobin cannot bind oxygen or carbon dioxide, resulting in loss of the hemoglobin molecule's transport function. Central cyanosis usually occurs when methemoglobin concentrations exceed 70%. Methemoglobinemia is readily reversed by the administration of methylene blue. Normal levels of methemoglobin should be achieved within 20 to 60 minutes after administration of methylene blue. So your answer is number 2. This is not true. Central cyanosis occurs when methemoglobin concentrations exceed 15%, not 70%. So methemoglobin cannot bind to oxygen or carbon dioxide, which results in loss of the hemoglobin transport function. Saturation will fall. Central cyanosis occurs when the concentration exceeds 15%. It is readily reversed by methylene blue and within 20 to 60 minutes. All are true about eutectic mixture except keratinized layer of skin, barrier to infusion. It is acts as a barrier to diffusion of topical drugs. The eutectic mixture is 2.5% bupivacaine plus EMLA, that is the eutectic mixture, is 2.5% bupivacaine plus 2.5% prilocaine. Eutectic mixture melting is basically the melting point of the combined drugs is lower than individual drugs, is lower than the drugs individually, and it diffuses through intact skin and blocks neuronal transmission from dermal receptors. So yes, the answer is basically, so your answer is number 2. So EMLA is actually a mixture of 2.5% lignocaine plus 2.5% prilocaine. Okay, it's not bupivacaine, it is lignocaine and prilocaine. So the keratinized layer of the skin is basically forms a diffusion. It forms a barrier to diffusion of any topical drug. So with this eutectic mixture, it can track through intact skin and block neural transmission, because the melting point of the drugs is actually lower than the drugs individually, which helps in penetration of this keratinized layer. All are true about local infiltration except the onset of action is almost immediate for all agents. The dosage depends on the extent of the area to be anesthetized and the expected duration of the surgical procedure. Epinephrine 1 in 2 lakh will prolong the duration of infiltration anesthesia by all local anesthetics. Epinephrine containing solution can be injected intracutaneously or into tissues supplied by any arteries. The answer actually is number 4. So epinephrine containing solutions cannot be injected intracutaneously to tissue supplied by end arteries, because it can lead to gangrene and ischemia. Okay, so basically your fingers, ears, nose, penis, these all have end arteries. Okay, these all have end arteries, that is, there is no alternative blood supply. So if epinephrine is given, it will cause vasoconstriction of these arteries and ischemia and gangrene. So onset of action is almost immediate during local infiltration, and dosage of course depends on the area and the surgical procedure duration, and epinephrine does prolong the duration. All are true about intravenous regional anesthesia except, so the IV injection of a local anesthetic solution into an extremity isolated from the rest of the systemic circulation by a tourniquet provides a rapid onset of anesthesia and skeletal muscle relaxation. The duration of anesthesia is determined by how long the tourniquet is kept inflated. Tetracaine is the most frequently selected for during this type of regional anesthesia, and alternatives include prilocaine, mepivacaine, and ropivacaine. So your answer actually is this number 3, not tetracaine. Lignocaine is the most commonly selected for IV RE. So basically a tourniquet is applied, extremity is isolated, and produce a rapid onset of anesthesia and skeletal muscle relaxation. Sorry. So All are true except, so this is the last slide for today. So all are true except cerebrospinal fluid does not contain cholinesterase enzyme. The duration of action of ester local anesthetics, amides based in the subarachnoid space, depends upon the systemic absorption of the drug. Local anesthetics may modulate inflammatory responses by inhibiting inflammatory mediator signaling. Inhaled lignocaine and ropivacaine attenuate histamine-induced bronchospasm and induced airway anesthesia. Site of action for spinal anesthesia is postganglionic fibers as they leave the cord in the anterior rami. So your answer is number 4. The site of action for spinal anesthetics is the preganglionic fibers as they leave the spinal cord in the anterior rami. So cerebrospinal fluid does not contain cholinesterase enzyme, hence the action of ester local anesthetics, which depends on metabolism by this cholinesterase enzyme, depends on systemic absorption of the drug because there is no enzyme in the CSF. So local anesthetics modulate inflammatory response by inhibiting inflammatory mediator signaling, yes. And lignocaine and ropivacaine inhaled can attenuate histamine-induced bronchospasm and induce airway anesthesia. So guys, that's it for today. That was today's class on the quiz, which included local anesthetics as well as your neuromuscular monitoring. I shall see you all tomorrow. I will be doing a special class. That is, I will be continuing my class on positioning and related complications in anesthesia tomorrow on the special class platform on the Unacademy app. So please do log on to the apps and please use my code SASHA and avail your 10% discount. Thank you guys. Have a good day. Have a good evening. Study hard, practice hard.